Welcome back to CEO Tradecraft. I'm Jason Radisson. Today we're going deep with Dr. Ken Holmen, President and CEO of CentraCare, a system whose North Star is making rural life healthier. We'll cover the parts versus whole tension of leading an integrated system, the role double whammy of aging populations and scarce talent, when AI truly helps and why it hasn't bent the cost curve yet, and how purchasing consortia like Panda Health and CAPTIS changed the game. Let's get into it. Ken, welcome to the show.
Good afternoon. It's a delight to join you. Looking forward to the conversation.
Me too. Maybe to start off, we both grew up in similar rural towns with families where going to college wasn't necessarily a given. Has that upbringing shaped your outlook, your ambition?
Well, it's a great question. I think lots of things can be true at the same time. One is that we are influenced and formed by those that are around us, our environment, as well as our people. Small towns are unique perspective related to the sense of community, a sense of family, and all that means. And then along the way, I have been blessed to feel sometimes the gentle and sometimes the firm guidance of other individuals that have helped. I call it, bumper bowling, where we're kind of bumped back into position. And that might be when I was in sixth grade. It might be as I'm a 35-year-old young doctor. It could be a number of things. So I think that we are formed by our experiences, where we were born and raised, and our parents, but also those influences around us.
You ever feel disadvantaged coming up, having started that way?
I wouldn't call it a disadvantage, but I think it was a hurdle. So when you come from a small town, there's sometimes a perspective that folks in the big city or have an impeccable Ivy League school education have a one-up on you. There's sometimes can be a sense of inferiority complex, or do I measure up? And so I wouldn't call it a barrier, but I think it's a recognition that sometimes people might look at you differently because of where you're from, the type of education. For example, I had no AP classes in high school back in my day in my little town, Iowa, simply because we didn't have any.
Right.
There was no chances for me to really do outside stuff because we never were on an airplane. And so I think this notion of how we're influenced in a small rural town, and as you look at more complex organizations, we are surrounded by folks that have a different upbringing, whether it's metropolitan or education or work experience. So I wouldn't view it as a barrier, but I think you have to recognize it.
And some things that could be superpowers, perhaps, right?
Yes. So I think that a sense of the one thing that I have noticed that I view as an attribute is a different sense of community and a different sense of personal. I use the word ethos, personal engagement. When I was a kid growing up, everybody you saw on Main Street knew you, called you by your first name. There was a sense of shared accountability, whether you were at school or a sporting event or in a grocery store or church or whatever it was. That sense of community was very connected. Whereas in a metropolitan environment, you are surrounded by all sorts of stuff that you may not have a personal connection with, a relationship with.
Yeah, absolutely. And if I can speak of my own experience, I think higher education is a different experience because as a financial aid kid and study and all the scholarships that helped me to get through college, it's very different than, if my parents were just paying full way and I was a consumer of college rather than a community participant of college.
So one of the things that you and I both shared, other than being from a small town, is the sense that people supported us on our journey. You would not be doing what you're doing in your career path unless somebody took an interest in you. And that is certainly true for me.
Yeah, absolutely. Would like to also talk about the moment where you came over to CentraCare and you were coming from Health Partners. I think you'd been chief medical officer. And as you took on the CEO role, what was motivation and how did you think about that transition?
So I think there's a historical context that is relevant. There was a lot of coming together of hospitals and health systems starting probably in the late 80s and early 90s. With the formation of some larger healthcare systems, not only in Minnesota, but also around the country. It was part of the way business adapts to changing market conditions. Along the way, most of the leaders of those larger systems happened to be folks with a business background. And at that time, physicians, for the most part, were in a private practice model. Did they practice in a hospital? Yes, but they were not part of the executive or management structure of those systems. So probably starting in the middle to late 80s, there was an interest nationwide to have clinicians, as physicians became more integrated into the operational model of these larger systems, to have physicians take leadership roles. In other words, transition from pure clinical roles or departmental roles into more active senior level management roles. And so I was a part of that wave, if you wish, or that momentum to have physicians migrate from pure clinical roles. For most of my early years, 25, 30 years, I was a pure clinician. Was I on boards? Of course, but my primary job was to be a clinician. And then as I went into Health Partners, I became mostly a full-time executive in different realms. And that then allowed me to develop skills that ultimately led me to CentraCare. And I've been here for a little over 10 years now.
And do you think that's an advantage? And how has health changed with this trend towards the clinician background versus the business-focused leader in that role?
So it's an interesting question, and my answer will be specific to me. It's fundamentally important to have a clinical background, and it's fundamentally unimportant to have a clinical background. So what do I mean by that? I find it of great value to have spent 30 years of my life practicing clinical medicine with my colleagues and taking care of patients, and understanding that despite the complexity of healthcare, and it's big business, it's very complicated, it is also fundamentally really personal. And you learn that in clinical medicine. So I find that of great value. That said, your effectiveness as a CEO of a large integrated organization is not dependent on those clinical skill sets that I learned and valued. It is more about how you create a team, the discernment about making the correct decision, and how you listen and understand the important stakeholders' perspectives, whether it's your team members, your senior leaders, your communities, et cetera, et cetera. So as I said, it's fundamentally important to me as a clinician. I love that experience. And on the other hand, it does not necessarily guarantee success as you get into a senior management role in a large, complex organization.
Hard to be able to balance and have that empathy ultimately for your teams and for patients.
And so there's been a change in that perspective from an educational platform. So many young physicians that are coming out now, younger in their career, in their 30s and 40s, will actually pursue an MBA or an MHA, knowing that they want to get into executive levels. Whereas in my era, to have physicians pursue that executive or management or business acumen was not expected or standard. It just happened.
How has the role developed? What are some of the challenges of dealing with such a large footprint and the integrated system?
So the way that I phrase this conversation is one that is focused on part and whole, or in many respects, diversity and commonality. In other words, it's a polar conversation. So what do I mean by parts and whole and diversity and commonality? Let's do parts and whole. Our organization is made up of many parts. It could be an individual department. It could be a family practice clinic in a town. It could be a cardiology department. It could be another hospital in another town. It could be the IT folks, finance folks, management. So we have a lot of parts in our organization, which is very strong and is fundamental to delivering care at a personal level. On the other hand, the whole, how we function as an organization in today's environment, is really important, because now we get at scale questions, infrastructure, IT. And so balancing the needs of the parts, whether you're a patient or a geographic location or a professional in a particular area, versus how does the organization thrive for the next 120 years, is a really a vibrant conversation where everybody has a personal perspective. Same thing with diversity and commonality. We recognize that we are in a very diverse environment. And for me, diversity means an individual. Typically use diversity in a realm of race or ethnicity or religion or sexual identity or preference. And that is certainly true, but every individual has a unique perspective that is diverse. And so how do we understand and respect that diversity, but also say, what are we doing together to improve the health of our communities? So I think that's the major challenge that I would focus on, is managing parts and whole, or commonality versus diversity. You have to do both.
Are there specific challenges of an integrated system versus a large hospital, urban hospital, or?
Well, those perspectives are individual. Clearly, me as a leader sees from a long-term, longitudinal, at scale, enormous advantages to the way we do our work. I actually believe it fundamentally improves care, and it fundamentally offers value to our stakeholders, whether it's our team members or patients. And at the other end of the scale, there could be an individual team member, nurse or doctor, that thinks that this is really stupid and it's bad. We might have a patient that has a bad experience. And so managing the perspective that is at one time at scale and also very personal can be a challenge. The challenges in healthcare are very real. They're similar to other industries, right? Reimbursement, revenue models, and cost models. And we also exist in kind of an unusual political climate, an unusual technological expansion, innovation climate, as well as a public health platform that is under stress. And so all of these unique aspects, some of which are common to other industry segments, but some which are unique to healthcare, fundamentally are the platforms in which we have to navigate, Jason, as we look at how we do our business.
Yeah. How about the rural component and, of course, so many areas of the economy under labor shortages?
Well, I think that there are several aspects. That one is a demographic shift. America now has more people over the age of 65 than under 18. And that has two impacts for healthcare. One is that there's a shortage of folks to take care of folks my age, right? We just have fewer young people in the pipeline, whether it's at college or professional schools or doctors or nurses. And the second is an aging population creates higher demand for services. So it's a double whammy in some respect. And that aging population is felt more acutely in rural environments. The average farm in America has grown significantly, and the number of folks on a farm has decreased significantly. You know, a farm might be 10,000 acres now. In the past, there were 10 farms that were 100 acres or 300 acres. And so the number of people engaged in farming or living in a rural community, I think we all recognize that rural Main Street has suffered significantly in the last 40 years as people buy more stuff online or go shop from Amazon or Walmart or whatever, the big box stores. And so the notion of some communities in our rural environments actually having a negative population growth is really a challenge to creating a sense of dynamic positivity, not only related to healthcare, but also related to the local school system. Schools are consolidating or the class size is shrinking. And likewise, the economic support of Main Street in rural America is being challenged. And many times a kid from a rural environment goes to a metropolitan area for education. They get their education there and they stay there, right? Because there's more opportunity. I'm not faulting them, but it indicates the complexity of the challenges for rural America. And certainly CentraCare, being a primarily rural-based integrated delivery network, faces those challenges fundamentally and also head-on.
Are there specific programs that you guys are trying or things that didn't work that surprised you?
So I'd maybe highlight a couple. Historically, healthcare organizations like us, Jason, were not involved in education. In other words, we hired folks that had received education elsewhere. We're not a degree-granting institution.
Right.
However, we've needed to invest heavily with our educational partners, private colleges, state universities, junior colleges, all sorts of programs in a very different way that involves our resources. That could be people, money, opportunity, space, technology, in ways that 25 years ago would not have happened. Why are we doing that? To create that pipeline for kids to stay in our communities, get an education, because we know if they get an education and experience with us, they're likely to say, cool, I can live in a small town, have 5 acres, live on a lake, have a great community, send my kids to a smaller school, safe. And so education clearly is an important initiative for ours at all levels of the folks that we hire, whether it's doctors or whatever, electricians, plumbers. I think the second thing is that how do we understand that in a rural environment, how do we provide optimal access to both primary care, specialty care services, as well as initiatives that improve community health? So we are working much more than we ever used to with community health organizations. It could be a public health organization. It could be a group of churches. It could be businesses. It could be the YMCA, United Way. And so this notion of improving community health beyond what happens in our clinics and our hospitals is really important. Most people don't spend their life in a clinic or hospital. Their definition of a healthier life is what they do outside of a hospital and clinic. So how do we invest in that very differently? Likewise, how do we invest in our rural economies in a very different way? In almost all of our counties and communities, we are probably the largest economic driver, the largest employer. And so we understand that accountability to make sure that our communities are safe, prosperous, have a sense of hope for tomorrow. So I think education, investing in the sense of shared community, improving the health of our community, and getting access to advanced technology and resources are all part of the calculus as how we serve our communities better.
Yeah, and what particularly resonates with me is also the holistic view of social connections and friendships and exercise that you can also partner with locally.
We have adopted for the last number of years a simple statement called making rural life healthier as maybe our North Star. the work that we do. It's not very fancy, but it's making is an action verb. Yeah, we're actually doing something. Rural, we talked about outstate or whatever, and we just decided rural kind of describes who we are and is meant to be an aggregator and a sense of shared who we are. Life is not just what happens in the hospital. Life is what happens at home and at work and around your friends and your relatives and your neighbors. And healthier is mental health, spiritual health, physical health. Health is health. It's all of us. And so making rural life healthier has been a very value-added conversation in our organization as we consider how to talk about revenue and then also where we spend money. How do we actually make rural life healthier?
Do you think there's a Minnesotan or a Midwestern component to that? Mayo and Medtronic, there's certainly a cluster here. We just approach health and community differently.
There's this phrase about Minnesota nice, and there's I think probably a truth to that.
Yeah.
I might answer that in two perspectives. One is subjective and the other is objective. There's a great deal of objective evidence on a national comparative basis related to healthcare outcomes and healthcare costs. Minnesota consistently ranks in the top 10 in healthcare providing and results in the country, consistently year after year. And I like to say that reflects a shared perspective of our healthcare institutions. Do we compete? Yes, but we also collaborate enormously. So it's a shared sense of purpose to take care of our neighbors. The second is I think that our educational institutions have committed to training healthcare workers in a very profound and meaningful ways, thanks to our educators. Third is I think our population, through their tax dollars, have supported a public policy program that expanded Medicaid, invests in research and improved health outcomes. So I think our legislators and the governors on both sides of the aisle over the years have demonstrated the value of working together to improve the health of our state. And last is our corporations. We are, as you mentioned, the home of some significant national players in healthcare, and they have embraced the notion of healthy team members and employees, as well as a sense of that as a state, if we get healthier, that's a good thing for our state, and it can be a competitive advantage. So that's the objective measures. Subjective, when I go to national conferences, I think that people always look to Minnesota and say, how is Minnesota so different from New York, California, or Florida? So that's objective, but there's a lot of subjective evidence that indicates that what we do is good stuff.
Well, I can also attest to certainly the sense of community and I think a healthy balance that we have in this part of the country.
But I would not rest on our laurels, Jason. We need to get better. And complacency has no place in what we do. And the challenge with addressing complacency and actually getting better involves moving someone's cheese, change management. And that is the difficult conversation of getting better. Mm-hmm. How do we get better with outcomes, with access to quality, to service, improved financial sustainability over time? All those require a sense of urgency, not emergency, but urgency, and a sense of forward momentum that does not rest on the past.
Absolutely. Speaking of technology and innovation, is it working? We think in tech of Peter Thiel's, we wanted flying cars and instead we got 140 characters. Is there something equivalent in healthcare?
Well, I think that I would classify Jason and Ken as kind of technology aficionados, but I will balance that with a practical, rational observation. One is that in a capitalistic marketplace, there have been enormous investments into technology. Number two, much of that technology is aimed at healthcare. And I'll give you some examples. One is the electronic health record. Another might be improvements in how we make drugs or vaccines, or even robotic surgery, or all sorts of things that have just made a profound difference in the way that we treat patients. So that's been really marvelous. And that technology momentum will continue, particularly as we bring on AI, generative AI, and other new modalities as computing power continues to increase and chip size continues to decrease. And so it's a really exciting time. Now, I'm going to balance that excitement with it has not fundamentally changed the cost structure. We're just spending more money on technology. And so the premise had been that all this technology would improve service, improve quality, and lower cost. I think that it has improved quality. It is improving service. But so far, the cost parameter has not been fundamentally addressed. And that's primarily is because technology is expensive to buy, keep, and maintain. There's always a new version coming out, as well as healthcare is unique in that we are fundamentally a people-serving people business. And we're trying to ride again a polar conversation between high-tech and high-touch. A lot of people want high-touch care. I get it. It's who we are. Fortunately, the younger generation, they love the two-finger typing and they're very facile. But we have a lot of patients who are frequent flyers for us who are in their 50s, 60s, 70s, and 80s, and they are not as technologically proficient as a 21-year-old mother. And so the notion of technology is increasingly important for our strategic planning, but it continues to be a hurdle for us to overcome from an implementation and a cost and value proposition.
Yeah, totally. Some of the advancements that are on the horizon, do they potentially bend the cost curve?
So I'll give you maybe a couple of specific things. So artificial intelligence has a way of accumulating a lot of data. And so perhaps our ability to do certain tasks. So I'll give you an example of reading x-rays. You can actually digitize every imaging study into a grayscale, right? And you can train, I don't like the word computers, but you can train programs that will read x-rays or imaging studies probably better than a radiologist with appropriate radiologic expertise supervising that. That will make a big difference. Same thing with lab studies. And you also might be able then to create an artificial intelligence algorithm that will take disparate information from an electronic health record and say the diagnosis is X and the treatment is Y. And so I think there's some real hopes out there related to information management, related to diagnosis and treatment. So far, in terms of helping us with a personnel issue, like actually taking care of patients, particularly in an inpatient hospital environment, has been challenging. We have clinical exam rooms that are what we are called smart rooms with ambient listening, DAX Copilot, that are really cool. It has decreased the burden on our clinicians from record keeping and note keeping. Patients love it. But we have not addressed really the fundamental challenge, which is how do we utilize technology in a way that's pleasing to our patients and our team members. Mm-hmm. That is the promise yet to come.
Yeah, and to me, there seems to be this sense of as much as we'd advance in diagnostics, we'd probably consume more services.
Yeah,
the human element of service.
So Jason, you're on an important soapbox item of me. Everybody has an individual perspective, which is really important, that they should get the health care that they deserve. Now, I'm going to go sideways completely for a couple of minutes, and I hope I don't offend any of your listeners. And I'll take it from two perspectives. One is from a patient perspective, and the other is from a healthcare delivery perspective. Let's take a patient perspective. If you are a patient and you want service X, Y, or Z, let's say you have a cold and you want to go to the emergency room, or you think you need to have your knee replaced, or you have cancer and you want to have the drug that you saw advertised latest on the TV, or you have a male problem that is really advertised a lot on television. You go see somebody and say, can I have that? And the answer is that is a consumer demand that actually may not be rooted in science. It's just that you're being sold something. And your definition of happiness or effective medical care is based on your interpretation of what you want, which may not be best medicine. Now, on the flip side, from a healthcare provider standpoint, when is the last time you walked into a car dealer as an owner and had the car dealer look at your car and say, you don't need a new car yet. You only got 55,000 miles on that thing. It works just fine. So our caregivers are in a tough spot. We have patients come in that say, can I have this antibiotic? Can I have that treatment, that MRI? And we know with a lot of detail what's best practice. But if you have a patient demanding something, how are we to deny that? When in point of fact, if you can't afford to buy a Cadillac, you don't go to a Cadillac dealer.
Right.
And so we have a bunch of misincentives in American healthcare that we're trying to manage at a very high level. It causes a lot of frustration at the individual and a patient and provider level.
Yeah. And there are so many treatments on billboards.
Oh.
Must be challenging. Are there countries that have it right at the moment? If we talk about comparative health systems.
So the notion of healthcare outcomes and what we spend on healthcare, so the value proposition, what we spend and what we get out in return, is one that people can make any one of a number of simplistic comparisons. So if you think healthcare in America is better, you point to the Scandinavian countries who have better health outcomes, and you can point to other countries who spend less on healthcare than America. And what happens is there's always an individual simplistic story. And the truth, as you can imagine, Jason, is complicated. One of the challenges with measuring healthcare quality is the metrics we use. And in general, there might be a couple of polar conversations. One is a population health measurement. That is how long you live, maternal mortality, newborn mortality, those kinds of things. In the Scandinavian countries, which have a nationalized health system, those numbers are in general better than America. The flip side of that, of course, is survivability, from what I would call more specialty-driven diagnoses, cardiac disease, cancer, rare pediatric anomalies. And in America, if you use that as a metric of success, we generally perform better than Europe. And that's because our system is designed more about acute care and ill care rather than preventative health care.
Yeah, absolutely.
The second thing is that from a cost perspective, the way that a nationalized health system works is fundamentally different than the way that our care system works. And as you know, when you compare cost structures, it depends on what's in that cost bucket. Are you including social services and public health measures, or is it just the accumulated expense of inpatient and outpatient and imaging and lab and pharmacy?
Yeah, it doesn't sound like there's really a leading model at the moment.
Yeah. And the nationalized health services, of course, they spend more money in their budget on public health services than we do. On the other hand, we spend more on inpatient and ambulatory models and imaging and lab. The other thing I should mention is that in nationalized health services, they buy healthcare stuff different. In general, the cost of stuff in America, and I'll pick out or noticeably mention pharma, drugs.
Yeah.
When in nationalized health companies, nationalized health service countries, the government uses their purchasing power to negotiate lower rates. Whereas in America, it's up to us as individual hospitals or systems to negotiate rates, so we generally pay more.
And was that some of the thinking that led you and your partners to start Panda Health?
That is correct. So Panda Health is an example of what we would call a combined purchasing organization. Mm-hmm. It's designed specifically at technology and all the technology explosion, whether it's wayfinding, to access, to communication, to billing, to diagnosis. And we belong to another group purchasing organization called CAPTIS with a number of other leading healthcare organizations. And that's where we buy stuff. That could be a heart valve or a cardiac stent or all sorts of stuff. So it's a way for us to come together as organizations to negotiate better pricing, whether it's technology or even the stuff that we use.
And if we look ahead to the next 5-10 years, what kind of changes do you think are coming? I mean, in addition to AI, or is AI the big one? Or are there reimbursement changes coming, new care models? What are the things that you're excited about or that keep you up at night?
They do both at the same time. You know, the Chinese ideogram for danger, the flip side of that is opportunity. And so as a leader in today's complex environment, you have to face reality and be optimistic about tomorrow. So I would start number one with workforce. We have workforce challenges, fewer people and more demand. And we had counted on an immigration policy. I'm not talking about the southern border, but an immigration policy in which many healthcare workers were immigrants, whether it was nurses or doctors or more custodians or whatever. The second would be the revenue and cost mismatch. More and more of our revenues come from a government source, either state or federal. For us, it's nearly 70%. And so in a constrained conversation between our political entities, the appetite for more spending on healthcare at the federal or state level is minimal. So we face for the same level and quantity of services, restrained revenue, top line growth of, pick a number, 2%, 3% per year. And our cost structure, which is for the most part people, roughly 60%, and stuff, which is 40%, that cost structure is going up 3 to 5 to 7% a year. So that means that every year you have to pick up a 4 to 5% differential of revenue versus cost. And doing that year after year from an efficiency standpoint is really challenging. So cost and revenue implications. Third is, I think, this notion of how do we address, everybody wants American healthcare to get better and cheaper. So what does that conversation mean? We have thought that pure capitalism will drive down healthcare costs. And the challenge, of course, is that it does not. So what's the new models that we need to address healthcare? Fourthly is, I understand everybody has different political perspectives, but having profound ideological perspectives on broad sides of different poles is not conducive to a strategic planning process in healthcare that frequently is 5, 10, 15, and 20 years out. So how do we plan for the future when there's just chaos all over? And so I think those would be the major themes, Jason.
Interesting times ahead, for sure. How do you think the role of CEO of a major health system evolves, changes? Do you think it stays the same? Will there be different needs in terms of that profile and the experiences somebody should bring to the job?
That's a fabulous question. We just did a survey. I participated in a survey by an outside party. on attributes of successful CEO in today's environment. And I think that there would be two major themes and an overarching river. So the two themes is an increasing emphasis on how do we perform today and how do we plan for tomorrow. Got to do both. The river that connects the two is the challenge in that I think the notion of leadership has changed tremendously in the last 10 years. It is very complex. It is managing ambiguity. It's about understanding the needs of stakeholders who may be, yards apart, and coming together about the right decisions. As I like to say, it is the discernment around making the correct decision. So it really requires thoughtful leadership that listens, but at the end of the day is not afraid of saying, we're going to climb that mountain. And then how do you get the leadership and the troops with you to help climb that mountain together? And that's a different leadership skill.
Yeah. It definitely leading from the front, the complexity of the decisions that are required also.
Yeah, very true, Jason.
How about for people entering healthcare, whether it's on the clinician side or potentially future administrators? Any advice in terms of what skills you think they should be emphasizing, which skills will likely be in decline?
So I'd make a general overall comment. Lots of times in a industry segment that's under stress, the folks in that industry segment can not be very resilient and have a negative cast on what they do. And I don't share that perspective. Being in healthcare is a marvelous career. What else can you do that will offer you a fair compensation in a way that profoundly helps people? That's really cool. And so I'm very bullish about folks going into healthcare, understanding that the world we live in is unknown, but when was there a knownness about the next 5 years? You go back to the founding fathers or go back 1,000 years. The notion of change is constant. So I'm very bullish about healthcare as a career. And I think that as you enter the career of healthcare, lean on that sense of purpose, find out where your strengths and skills are, find people to bump you back into lane and learn from, and then find something that gives you pleasure and joy. And I think that's the secret to how I would encourage young people to approach healthcare. It is a fabulous career. I'm not saying it's easy. I'm not saying it's not without bumps, but it is remarkably fulfilling.
Well, I think that's a great note to end the show on. Ken, thanks so much. And thanks to everybody for tuning in. We'll see you next time.
And thank you, Jason, very much.
Big thanks to Ken Holmen for a candid playbook on rural healthcare. My takeaways: lead the parts and the whole at the same time. Invest upstream in your workforce and balance high tech with high touch, because patients still want humans at the center. If this has sparked ideas, follow, rate, and share CEO Tradecraft. I'm Jason Radisson, and we'll see you on the next one.